and implement it when you go through such workshops. So with this positive energy, we'll go on to day 2. Yesterday was foreign body management, end-to-end, exhaustive, meticulous, threshed out, and I see that the image is already flashing. Over to you, Dr. Mantri, and if the other chairperson is a little late, then Dr. Samir can take over till they join. Thank you so much.
Hello. Good morning, everyone. Switching gear from foreign body to versus air leak or bronchopleural fistula.
He specializes in thoracic radiology. So, Dr. Harish, over to you.
MDCT is the most important and diagnostic imaging of choice presently. Nuclear scintigraphy can aid in diagnosing in subtle fistulous cases. So by definition, any pathological communication between the pleura and airway is called bronchopleural fistula. It can be between the bronchus and the pleura, or it can be from just a parenchyma, that is alveolar-pleural fistulas, a pleural cavity. So broadly they are classified into either bronchopleural fistula or alveolar-pleural fistulas. Again, central or peripheral bronchopleural fistula, because central are which are very close to the main airway, and over a period of time the post-pneumonectomy cavity is completely opacified. So when to suspect bronchopleural fistulas in post-op chest X-ray? So either it is appearance of the new intrapleural gas or failure of the pneumonectomy cavity to fill in with the fluid. So if it is single subpleural blebbar cavity, it's very easy to identify. Where we can see the post-occlusion, there is complete resolution of the pneumothorax. So one more example is when we see on the axial images, sometimes we feel it is just alveolar-pleural fistulas, but on reformatted images we can see there is bronchus leading to the fistula. It will convert into bronchopleural fistulas. One more example, on axial images we can see only small cavity, but on coronal reformatted images it is the bronchus which is leading to this thing. But what is the advantage of this? Because whenever there is bronchus leading to the pleural surface, definitely it needs more surgical intervention than compared to the just alveolar-pleural fistulas. So some authors have tried using contrast CT after bronchoscopy, but I think this use is obsolete in the present day advanced CT machines. So CT is definitely most useful and imaging modality of choice, but when there is fully or the cause of pneumothorax, probably we have limited limitations in identifying the fistulous tracts. So nuclear medicine is having limited, earlier it used to have important role, but with the advance of thin slice, multi-slice CTs, I think it's no more used as a practical aspect. So using nuclear scintigraphy, the specificity and sensitivity is very high, but it needs utmost patient cooperation. In uncooperative patients and critically ill patients, it's often difficult to demonstrate the fistulas. So can a radiology play an important role in clinical management? Yes. Depending on the whether fistulous tract is single, multiple, it is coming from the single lobe or single segment or entire lung, definitely we have to block the corresponding, if the fistulas are corresponding to the single bronchus segment, we can go and occlude the single bronchus without compromising the other healthy lung. So underlying cause of BPH should be identified and treated along with the fistula itself. So studying anatomical relationship with some of the important complications, that is pseudoaneurysm following the either cavity, tuberculous cavity, whatever it is, and hypertrophic bronchiolitis have to be addressed simultaneously before going for the treating the bronchopleural fistulas to avoid treated complications. One study has correlated when CT was showing the bronchopleural fistula on CT, so there was need for more surgical intervention compared to the non-identification of the bronchopleural fistulas on CT. That is because most of the bronchopleural fistulas which we have identified on CT is bronchus which is leading to the pleura, whereas alveopleural fistulas are the one which is self-limiting, can limited to the bronchus. So in summary, whenever there is new air in the pneumonectomy cavity, always suspect bronchopleural fistulas. CT useful in identifying and localizing the fistula and number of fistulas and underlying pathology. And when fistula is seen on CT, definitely it is candidate for surgery most often. And when ruptured bulla or the cysts are the cause of air leak, we may often not be able to identify in the CT. Thank you.
Thank you so much.
Of etiology, you're looking at it from the point of view of fixing the problem, which is either some sort of bronchoscopic strategy, which is the main focus of today, or a surgical strategy. So what tips would you give them? How would you look at the CT differently compared to what you were doing before from the point of view of prolonged air leak?
Yeah, whenever there is a clinically visual discontinuity is one finding we have to look for when there is persistent air leak in spite of occluding the visible bronchopleural fistulas. So visual disruption, again one more problem with these patients. If the patient cooperation is good, image quality is good, we can easily identify the...
All these can be missed on a cursory examination of the CT. I mean, because there are radiological, interpretation variabilities at all levels of practice.
Yes, sir.
So what do you recommend?
Yeah, one is particularly for bronchopleural fistulas, because otherwise more than 1.25 usually we reconstruct images. But when we are dealing with the bronch, what I advise, rather than seeing images in your respective OPDs or wards, I would recommend you to always review the images in the CT room.
Thank you.
Because PET CT images are too thick for identifying bronchopleural fistulas. Even if you recon PET CT images, image quality is very poor. We don't often recommend.
And sir, how the nuclear medicine help in localizing PPF? What exactly the mechanism is, as you mentioned?
No, nuclear medicine usually whatever when we inhale the xenon.
Ask them to cough. If it is severe during inspiration and expiration also, you can see a bubbling. That's why we say that it is a PPF or really clinically. But in a radiologically, you do any maneuvering, like you make inspiration and expiration, ask them to cough and do a particular way of doing it as a protocol.
CT is very sensitive for motion, so we need utmost rest. Cooperation from the patient. We don't ask patient to, because we have to hold the breath while scanning the patient. So there is no role for these maneuvers. Only thing we would recommend is put negative pressure and set as much as possible lung towards the chest wall, so that we can see more, we can stretch the visceral pleura and we can identify the collapsible nature of the bronchopleural fistulas. That's the only role.
I think we want
Giving an overview about PPF, I think it's
Online audience to know that they can send in questions as well. We will be looking at the questions sent in by the online audience as well. Dr. Dharmesh, you had a question.
How does that help? What's its function, basically? And can looking at the underwater seal reflect what's going on in the visceral fluid as far as the leak is concerned?
yes. So essentially, it's a bubbling.
Pawan might be touching on it. There are some dry system drainages, right, where you don't apply the water seal.
We will be.
Synaptic.
So we'll have that on the ambulatory devices.
The fluid after a pneumonectomy, is there some thing that helps to determine whether the fluid is related to a dehiscence or a BPL formation, and it's not the normal fluid that one expects as a draining pneumonectomy? So I don't know if the question is about whether there's any markers or indicators, radiological or in the character of the fluid. I think Dr. Harish already mentioned the changes that we see radiologically. The question is probably about the character of fluid. Does that tell us if there is a change in character that one is looking for, which says this is not the normal drainage, but...
Good morning, everyone. Thank you, Prof. Ravindra, for this kind invitation. So I'm really very happy to be here today to be sharing with you on some insights on persistent ALIC. I'm just going to go through principles of management, but there might be some overlap with the previous two, pathophysiology and persistent ALIC, and as well as the physiologic effects of chest drainage, and then common chest drainage systems just a little bit, and finally to review the therapeutic options for PAL. So as mentioned by Dr. Harish, so basically the persistent ALIC can be classified or categorized into either post-operative, right, which are usually the bronchopleural fistulas, as well as the non-operative or the alveolar pleural fistula. So I like to use post-operative and non-operative, so that would be sort of the nomenclature that I'll be using for the rest of this lecture. So also I think Dr. Karen touched on this. So the problems with having a persistent ALIC is that is threefold. Okay, number one, there is a breach in the pleural space sterility, right? So that's communication.
Thank you so much, Dr. Malvante, for the clarity, ventilatory pleural mechanics, and an overview of sealants, pleurodesis, and more. I'm going to open it up for questions from the audience. We can probably have time for maybe a couple of questions.
Thank you so much. This is Ravi Mehta, and thanks so much. And your in-depth knowledge of physiology combined with the integration of critical care and spontaneous and mechanical ventilation is always so interesting to watch. So now the question was, I think the practice of, since you took the topic on overview, the practice of PAL therapy seems to be so different country to country, right? I mean, it depends on what you have, what you do, whether you are a pulmonologist oriented country, you are a surgeon oriented country, what do your laws allow, and so on. So we're just trying to put so much of this heterogeneous stuff into one mix to give one common message. It is quite difficult, I understand also, but is there some common thread you would like to leave for everybody, that this is the level at which you can go? After that, it depends on your infrastructure, skills, and so on.
Well, I think, if you really want to...
And taken into various levels of understanding physiology, CT scans, and so many other talks, which are going to help to comprehend this better from a therapeutic point of view. Thank you so much. Back to the chairperson.
Moving on to the next topic, Apollo colleague is working in Mumbai now. Welcome, Pawan.
Thank you, chairpersons, for that access with the previous talks. And I'll try to briefly go through the details on the pleural drainage devices. Sure, it's working.
Give it a second. Yeah, take a minute.
So I'll be concentrating more on the pleural drainage devices, and in this talk we'll go through the indications of these devices, principles of ambulatory management, history of pleural drainage, and various pleural devices which are available in the market. So most of the ambulatory management is a conservative management. It's not working properly. Can you change the slide, please? Okay. See, the ambulatory management is mostly reserved for the alveolar pleural fistulas or small BPF. A larger BPF will require a surgical management or bronchoscopic therapy. And these are the patients who are not surgical candidate, or those who refuse for surgery. Those are not candidate for bronchoscopic management, especially when you have extensive collateral ventilation. You will not be able to block a particular segment or multiple segments are involved. Then these patients should be subjected to ambulatory management. And if you have a pleural space infection because of these leaks, if there is a empyema, then it's mandatory to evacuate the pleural space, and that's how the ambulatory drain will come in picture. The conservative management is mostly based on the principle of you have to evacuate the air and the pleural space to assist the re-expansion of the lung, promote the natural healing of the air leak, and prevent contamination of the pleural space where the drain is inserted, as well as the contralateral lung to be protected from infection. So the advantage of the drain-based care is it's a very less cost involved compared to a surgery or a bronchoscopic management. There are many devices available in the market. The skills required to maintain these devices or put a tube are very simple and easy to teach. They reduce the length of hospital stay for sure. You can discharge these patients once the patient is clinically stable, and they are very useful for post-op alveolar fissulas, as Dr. Madan has pointed out, and the previous speaker also pointed out. That 70% of BPF will heal on with the ambulatory drain management only. So if you look at the evolution of pleural drain, it starts from the Hippocrates, which has described major medical procedures from 460 BC. They use the redissection and open drainage so that the empyema is evacuated from the pleural space. The closed water drainage system has been used from 1875 and it has been rapidly used during the influenza epidemic of last century. Three-bottle system has been in use from 1950s, and the current disposable drain has been in practice since 1967. After that, it has undergone many modifications, which we'll see through few next slides. The ideal drain should have following components. There should be a drain tube which connects to the chest tube of the patient and to the device, where there is a collection chamber. There should be a valve. The valve will prevent the entry of the. If there is only air leak, you can just manage it with a Hemlich valve. If there is small amount of fluid is present, then you can use a small chest drains like a Sinapi system. If there is large volume effusion, then a mobile dry seal drainage system should be used like a Sinapi or atrium. And if there is pneumothorax with continuous suction or requirement, or if there is effusion, large amount of effusion post-op settings, then digital drains are better. Suction versus no suction is an institutional practice, and patient and family has to be educated well regarding the device use, their monitoring, and when to change, especially when you are using a home care. And access to your out of our pleural services should be there. Your ER should be trained about the managing of this device, detection of blockage in the device. And for Indian setting, I think we need low-cost indigenous devices to serve our patients better. Thank you.
PL management compared to the other devices.
So the dry section, dry seal devices should be preferred if all you are managing at home, because some amount of fluid is going to be there during the drainage. So there is a lot of soakage with the valves which happens on the skin. But it should come down to the cost of the device and what your patients will be able to afford. The Sinapi drainage as well as the OSS drainage, they function the same.
No, thanks. I think this is one of the most comprehensive chest drain descriptions we've ever seen. So thank you so much.
Invite Dr. Pattabhiraman to come on stage. He is Chief of Pulmonary and Critical Care at Royal Specialty Hospital, Coimbatore. We will be talking about bronchoscopic approaches towards leak localization and planning therapy. Over to Pattabhiraman.
Thanks, Jain. Thanks, chairpersons. First, to thank Ravi for giving me this opportunity and for setting up this important discussion on both PAL and foreign body, which is not very common. So, what I will be doing is just touching on the basics of case selections and leak localization using bronchoscopy. I'll not go into the therapeutics of it. So just the types of PAL, I mean, there will be considerable overlap, the nature of the discussion is that you will have a small topic and there will be considerable overlap. It's quite okay to get it reinforced. So it is looking at how to localize the leak, what are the techniques, what are the pitfalls and the role of fixture integrity. Already been alluded to by the radiologist, and somewhat I think are important take-home points. So there is a difference between a bronchopleural fistula, which is the proximal communication at the level of main or segmental bronchus, versus APF, which is beyond the respiratory bronchiole. And this will not be visible on a bronchoscopy. And the common clinical scenarios are what happens in a necrotizing pneumonia with a pleural communication, which is the most common thing in infection with secondary involvement of a pleura, or a patient with a pneumonia on a ventilator develops a percentile or a spontaneous pneumothorax with PAL. Tuberculosis can have both, it can have both a peripheral thing or even a central bronchopleural fistula. Whereas a bronchopleural fistula alone is typically a post-surgical or a post-transplant dehiscence. The differences are APF, the leak is distal, can be difficult to localize, can be multiple. The size of communication is typically small. The collateral ventilation is an issue. That's when the fissure integrity also plays an importance and may settle down with time. So APF, Usually given some time it settles down. Whereas a BPF is a more proximal, never a problem diagnosing it. It's usually a single communication, the communication tends to be a little large. Collateral inhalation is not an issue at all, but it's unlikely to improve by itself, and so if you have a big BPF, you might have to handle it. So what are the guidance, I mean, how will you, what are the things that will guide you as far as how long can you wait? Volume, large volume, may not stop, and so you might have a problem with a large volume leak. And a duration, typically wait for 1 to 2 weeks. I mean, if you have a spontaneous pneumothorax, if you have a chest tube and then you find that there is an air leak, how long can you wait? It depends on whether it's a spontaneous primary or secondary. But the more important thing is the trend of the leak, where day 1, day 2, day 3, and if you find that if this folio grade 4 becomes 3 or 3 becomes 2 and all that, and then that means that there is something that's going to go all right. So conservative measures can actually help. So how do you time it? And this came out, I think Dr. Tay was also alluding to this particular paper, where there is a persistent air leak in spontaneous pneumothorax. What is the clinical course and time? If it's a primary spontaneous pneumothorax, about 75% of them recover in a week, and about 97%, close to 100% resolve in about 2 weeks. So if it's a primary spontaneous pneumothorax, just put in a tube and then wait. Whereas in secondary spontaneous pneumothorax, 2/3 of them improve in a week, and after that you might be pushed to do certain things. So this is what he said. So wait between 1 to 2 weeks, 2 weeks for primary, and a week, and look at the trend for secondary spontaneous pneumothorax before you try doing something. Post-surgical, again, I think it was discussed, especially this particular paper was discussed, how it was managed in terms of an ambulatory setting. So this is again done by Serfolio himself, and this study was purely about post-procedural air leak. About 8% of them developed a air leak on a POD4, and for those people they did an ambulatory thing and reviewed in 2 weeks, and they actually provocatively clamped and removed most of them resolved. So that is where this magic 2 weeks came. Whatever be the reason for air leak, wait for 2 weeks, even in post-surgical things settle down. So this is what came as a paper in Predictors and Treatment of Persistent Air Leaks by Serfolio and group. And this already, I think Karan took us through the predictors of PAL. Who are the people who are have developed a propensity and who actually will not really get better unless you intervene. So how do you decide to intervene? You intervene after conservative measures fail. How long you wait? There are no guidelines here. Surgical intervention may be more definite, but a population who fit for surgery needs alternate, who not fit for surgery, sorry about that, needs alternate strategy. There are no guidelines at this point. The best that they could come up with in 2023 was it's probably useful to have some endobronchial thing. That's what I think Dr. Tay was also saying. CT would be an important thing to localize, and that we had a good discussion. Bronchoscopy gives a vital info regarding localization of leaks. So CT, especially the reformatted, like in this case, you can see that there is a upper lobe anterior, there is a bronchial thing that actually leads on to this. Whereas in bronchoscopy, if you have such a kind of a thing, this is the right middle lobe, and if you do a bronchoscopy, this will be a more definite way of identifying or localizing leak when the bronchoscope actually goes into various subsegments and ends up in a space where you can see an ICD. So this is the easy way to localize. But this is a very large leak where bronchoscopy is inside the pleura and you can see the ICD. There is no problem with localizing. Whereas bulk of it you localize only by doing what you use by using a balloon. A simple Fogarty balloon is the one that you usually use it. Now, how do you do that? Typically we use a patient who will be sedated, ideally with an endotracheal tube, a big size to give a better seal. You use a bronchoscope, you have a Fogarty balloon, keep the ICD bag visible. So these are the things that you start up front. You start by occluding the main bronchus, because obviously you have a right-sided air leak. You occlude the main bronchus and make sure that the leak stops. So that is just to test whether your apparatus is working. And after that, you go from proximal to distal. You wait for 3 minutes, 2 to 3 minutes, because once you stop the airway and then you ventilate, till such time that air distal to that goes off into the ICD. So there will be some kind of a bubbling that happens after you close it. Doesn't mean that there is a leak. So wait for things to settle down and then you decide. But then go to global, segmental, further segments if possible, based on what your CT shows in a certain alveolar pal, but it's not very simple. Now, what are the challenges in localizing leak? Let's just think about this. Think about the fact that you balloon block it does not stop the leak. However, if you look at the CT, there is a leak exactly from the place that you've seen. So the radiologist has seen, you've gone to their department, you find out that it is in certain section, upper lobe anterior, A to B and all that stuff. You go and then block, it doesn't show. Why does that happen? It might happen because of a fissural integrity. So that is one thing that you should understand. And also, you have a bulla and you know that this is a bulla that is ruptured. You remove that bulla, the surgeon removes that. There is still a 20% recurrence in pneumothorax. Why does that happen? Also think about this. Why is it that a pleuro disease is more important than when preventing pneumothorax than just removing the bulla? So there are studies which shows that if there is a bulla and then you remove the bulla and not do a pleurodesis, there is high recurrence. Whereas if there is a bulla, you don't remove the bulla, if you do the pleurodesis, then it's a much better thing in terms of preventing a recurrence. So why are these things happening? It's happening because of an entity called pleural porosity. It's not a single point. It's not that bleb that is causing a problem. It's not this small number of blebs which is rupturing the time of thoracoscopic surgery, whereas the remaining areas around the blebs are also very porous. Those are called as a pleural porosity. These are the areas of disrupted mesothelial cells. These are replaced by an inflammatory elastofibroblastic layer with increasing porosity allowing air leakage into the pleural space. So that was actually shown by applying a dye, and then you see the whole red color thing is that the whole area is porous. It's not a leak that happens in a single bleb. So that is the reason why you also do a symphysis procedure like a pleurodesis after doing a bullectomy. So these are the issues with the bronchoscopic leak localization, where you stop you find out in a CT there is a bleb here and this is the airway that's leading, you just block them, and this still you might not be able to see that the localization is proper. There is also this incomplete fissure thing, and the collateral ventilation which can cause a problem. More than one segment can contribute, and there is this pleural porosity. So these are the issues why your leak localization with the bronchoscopy can fail actually. But since there are certain, there's a good percent of chance that you might actually do that, so you'll have to do that. What are the other issues? Because you're ventilating the patient, the air leak may reduce or it become intermittent after an anesthesia or induction for bronchoscopy. So that is also something that you'll have to factor in. A small endotracheal tube can cause a problem, and also to circumvent this, some of the people have used an endotracheal oxygen insufflation to make sure that the leak shows up when you're doing this procedure. The other bronchoscopic methods like a methylene blue instillation through the bronchoscopy, you put in a catheter and then instill a methylene blue, and xenon gas was also discussed in the first session, or an EtCO2 measurement coming from different lobes, and you find that certain lobes the EtCO2 can become less because some of the air is going out into the pleura, and so whenever segment, in some segments if the EtCO2 is less, then you know that that is the segment that is actually leaking. Again, we have the CT, and just let's look at how it is done. So you can see that this is the bag that is visible, and you can see that this is a patient who had a right anterior, upper lobe anterior, and this is a cerfolia grade 4 now. Because this patient is ventilated, it's usually grade 3 become grade 4 on the table also, so you should also appreciate that. And then you can see that you close the upper lobe anterior using a Fogarty, and you can see that this leak stops. So you can see a considerable stop. What was the cerfolio 4 became 0, or at least 1. So this is how you see, and all you're looking at is reduction in the size of the thing. You don't even need to see the stoppage of things. So even if there is a reduction, you know that that is a segment that needs to be tried, in terms of a therapeutic thing. And then you stop to confirm what we have done is you just reduced it, or rather deflated the balloon, and you can see that the airway comes back. And so this is how it starts. It's a cerfolio 4 when you start off, but once you occlude those areas, you actually can reduce the leak, and you know that this is the place that you got a leak. So take home points are usually wait 1 to 2 weeks before you start anything like a bronchoscopic leak localization. So wait, if you have a peripheral persistent dial leak, especially, you wait for at least 1 to 2 weeks. You consider the surgery in case of a large BPF because you can't do it, especially if it's post-op and it's immediate. The surgeon has to do surgical procedure which has a higher ability. Leak localization, including using a balloon occlusion, is a vital first step in the interventional approach, and that starts well within 1 to 2 weeks. Be aware of the difficulties and pitfalls while embarking localization. You might end up not seeing a reduction in leak despite the CT showing a very clear evidence to the same thing. Be prepared to extend the procedure. This is the most important thing. When you do all this, you're putting the patient on a ventilator, you're just doing a major procedure. Just for a leak localization, no. Always be prepared to go ahead and block this, and that's going to be the topic subsequently. So once you have this, you see this is the same patient that I'm. Can you just play that video? I mean, this is the last thing. So, I mean, this gives you a better idea. So, we have the Fogarty, right upper lobe, and you can see that this leak is stopped. You can actually confirm it. You go further distally between the two subsegments, and then you do it, and then you can still see that. So, you can actually, we got that smaller area. So, you go as distally as possible. And now you can leave that Ravi's spigot that we did, and that will be in the session in the evening. So we just put in a spigot and immediately stop. So whenever you do a procedure and diagnostic thing, don't do that and then come back. Just be prepared to do a therapeutic procedure also in the same setting. And I'll be happy to answer questions then.
Thank you, Patabi, for the running late.
In the BPF of grade 1 and 2, set-folio grade 1, we will face the practical problems, like if the patient is already sedated, when we are trying to localize the BPF, so maybe it is when it is BPF will be only on force expiration or expiration only.
No, so it changes once you intubate and then ventilate, it becomes a different thing. You're forcing stuff, so you might. There are two things that can happen once you start ventilating. Either the leak can stop because of the smaller tube and lung can have to collapse, and so you might stop that. I mean, you will suddenly realize that there is no leak after you thought you should be doing. So for that, you need to use a bigger tube, and that's why there are certain people who use an oxygen insufflation or some kind of a thing to ensure that in each segment, and then find out whether the leak appears. And the second thing is, you could also, because of the positive pressure, you can have a bigger leak than what it was in a.
This is the most common practical problem that we face when trying to localize. If it is a small grade, and before the procedure, if you say, like I am doing in a conscious patient, for example, if you are doing if the column is moving like 10 to 15 centimeters before the procedure, so after we localize, after we block it, so how much percentage to be reduced?
No, I think it should be eyeballing, and if it reduces, then you know that it is there. I mean, you can't really have any number to that particular thing as far as I can.
Thank you, sir.
Thank you,
Bronchoscopic approach endobronchial valves by Dr. Udit Chadha. May I hand over to Dr. Udit Chadha. Not audible. No.
Hello? Okay, thank you. Okay, so first of all, thank you to Ravi for the kind invitation. I apologize if any of these slides overlap with the last talk, and I did notice that some of the content will be repetitive. And I also want to clarify that this is largely an evidence-free zone, so a lot of what I present here will be opinion. So feel free to contradict and ask questions. So I'll be dealing with valves mainly, but I wanted to just generally touch upon some aspects that have been touched upon already about persistent air leak. Largely the definition is if you have failure of re-expansion of the lung with a persistent leak for 5 to 7 days. And as has been discussed, that this number is arbitrary. 5 days was the expected length of stay after a lobectomy, and that's where all this hoo-ha about 5 days started. So it's a very empiric definition, and as has been touched about, the most important thing that we need to look at is a trend to improvement. And if you are seeing a trend to improvement, the key is to wait. So if there is a trend to improvement, be patient. If there is no trend to improvement, do your best to get the patient to water seal, underwater seal, if
that has not been done already. And the benefits of water seal come mainly from surgical data. A study in 2001 from Surfolio where they randomized 140 patients who were post-op, and 33 of them had a leak on day 2. By day 3, the patients who were randomized to water seal, 67% of them had complete resolution of their air leak, while only 1 out of the 15 patients in the suction group had resolution of air leak at day 3. And those patients who did not have a resolution of air leak on suction were switched to water seal on day 3, and 13 out of the 14 of them had a resolution of air leak on day 4. In the second study on the right of the screen, we can see that patients were randomized and there were 15 patients in each group, and the duration of chest tube was shorter and the duration of air leak was shorter in the patients randomized to water seal. This basically shows that air leak goes along a pressure gradient, and if you place someone on water seal as opposed to suction, you are no longer perpetuating that leak. So you are allowing the leak to heal, basically. And this has been touched upon, that patience is the key. In a primary spontaneous pneumothorax group, almost everybody had resolution by day 14, while 80% of those in the secondary spontaneous pneumothorax group had resolution by day 14. So if you have no tools at your disposal, and even if you do have tools at your disposal, the key is patience. And if you can get them to water seal and be patient, you're doing the right thing for your patient. You don't have to aim for complete lung expansion. You have to aim for resolution of symptoms and signs of distress. So treat the patient, not the X-ray. The value of patience was in a surrogate indirect way shown in the PSP trial. But I'll touch upon a video that was shared with me by Gary Lee and his group from Perth, Australia. And really when the lung shrinks down, I'll play this one more time, and you do not re-expand the lung, you are sort of allowing the wound to shrivel upon itself and therefore heal better, as opposed to when you put a lung to suction and then sort of stretch the wound and largely make it harder to heal. So in the PSP trial, what was noted, and this is definitely not even a secondary outcome of the trial, so this is obviously taken with a huge grain of salt, that the recurrence rate at 12 months was half in those who were managed conservatively as to those who had their lung re-expanded right away after a primary spontaneous pneumothorax in the intervention group. So let's say you do all of this. You try water seal, you be patient, it's still not working, right? Then you really have 3 options: surgery, pleurodesis, or some sort of a Pluto device. And I'm going to touch upon valves. So for valves, it is reasonable to try valves first if
Yeah, hi Udit. First of all, thank you so much. A few of the audience know that you're speaking from New York, where it's 1 in the morning. So greatly appreciated, and the alacrity and the content was really excellent and put things into perspective. So the question I had, Udit, was we've been struggling with these PL challenges, geographic issues, and a lot of the data which comes based on what people see in their own setup. So just dwelling on the first point, when you mentioned patience, point well taken. But then the caveat of patience here is, where do you draw the line? Is patience a function of the underlying pathophysiology? So being a Mumbai gentleman, you're very well aware of the fact that we have horrible pathophysiology. So does the patient's call get left shifted when you know that as an educated and smart pulmonologist that this is not going to heal easily? So does that also put things into perspective? Because linking to point number 2, the cost of patients in India is infection and a series of, you then double the problem where you not only have an air leak but you have an infected space also. So just to put things into perspective from the Indian from the Indian point of view, wanted to raise these points and get your thoughts on it.
Yeah, it's obviously just a judgment call, right? There are patients who will have a clear BPF post-op, and it is a rip-roaring air leak. You have a continuous grade 4 air leak, ongoing right from day 1 to day 2 to day 3. Now, in these people, you don't have to wait the 7 days. But on the other hand, if you have a patient with emphysema who has a secondary spontaneous pneumothorax, and you are noticing a trend where you are going from a continuous to an expiratory to a forced, and literally the consultation to me was, can you valve out the whole right lung? So a medical pneumonectomy. So really, you have to factor in everything. And your point is well taken that, some people you'll do it before 5 days, some people you'll wait for 14 days, and you have to factor in the risk factors for prolonged air leak in those patients.
So I guess patience with experience and due diligence would be the way to think about based on your spectrum, especially in this country of destroyed lung and post-tuberculous disease. The second question, and I'm sorry to hog the whole thing, chairpersons, but your controversy on suction versus collapse, that YC Gary Lee thing you showed is very interesting. 20-25 years, no one settled it. Experienced surgeons of yours who say suck it, take it up, and if there's approximation, you're going to get healing. And most surgeons will swear by that. Versus what you said, that let the lung shrink and let the healing happen. I think we still go by the suction part of it, unless it's a florid, absolute grade 4 leak where you're going to be in gas exchange suffers. Any thoughts on this? Because it's the first time I've seen a provocative, confident statement made by somebody that let the lung fall.
It's interesting that most of the surgeons fight for suction and the data against suction comes from them. Just to look at this. Again, I can tell you which, I've clearly expressed which side of the fence I lie on, because it is physiology backed to keep someone on water seal, let the hole heal, and then take it on from there. But the key here is your patient should be able to tolerate that, and you have to have the mindset to fight any other consultant to say that I am treating this patient and not the X-ray. So I can. Hi Sajjan, how are you?
I'm good. So I have a different question, different from your topic. It is on iatrogenic pneumothorax. So we do a lot of cryobiopsies on patients with interstitial lung disease. So several times we encounter a pneumothorax. So what is your take on doing a pleurodesis in such patients? They have a bad lung, but it is an iatrogenic pneumothorax, and the patient might become a transplant candidate. Your take on pleurodesis in such patients?
So in general, the dictum and even the BTS guidelines recently just touched on this with iatrogenic pneumothoraces is not to pleurodese because you cannot predict their recurrence rate. Anyone with a secondary spontaneous pneumothorax will have a high recurrence rate. Of course, the degree and the risk of recurrence will vary depending on what their underlying lung looks like.
From AIMS, just a quick question. So just wanted to ask you that now since that valves are available with you, are they your go-to choice for any bronchoscopic procedure for leak closure, or you have some other options which you also consider as good alternatives?
So I can tell you about my practice. I mean, everything we do in this space is off-label. So if
with a forced expiratory leak, this is not going away say after 10 to 14 days, you still try that blood patch thing there, autologous blood patch.
So I'm sure you're very familiar with blood patch data, Sajal. So patch or does it pleurodese? And I stand on the side of pleurodesis, I do not stand on the side of patch. But again, there is no clear understanding of how blood patches work. Do you need to do one blood patch? Do you need to repeat it on day 3? Do you again need to repeat it on day 5? So really the key answer for us is that we always try a blood patch, because if someone
can approach, throw something in there, whatever it does, whether it irritates the pleura or shuts off a hole, you're just going to be happy with that. The second problem we found with blood patches, and we've never been able to replicate the literature of 82%, is infection. If these guys have been with tubes long enough and you try a blood patch, the chances of somehow infection go up because you're instilling some 7500 ml of blood, and you may be doing it repeatedly, and then you may convert into a worse empyema. Again, Indian setting, anecdotal observation, but it's worried us a lot. And then again, you're complicating the issue more. The only thing we did not do is send a blood culture of these guys before doing a blood patch. But short of that, it's been a problem for us to deal with some of them as a consequence. Well, the late part of it is part of PA's story. On one side you're patient, the other side you're late. So we can take on, next time I'm throwing in a topic on controversies in PA, I can throw in all this stuff. Early versus late, suction versus no suction, have a lovely pro-con debate. Udit has stirred this small hornet's nest, so to say. But anyway, thank you so much. Interest of time, I think I hand over to the chairpersons. Udit, personal thanks to you. Thank you.
Thank you.
Speak out. We are not able to directly visualize the BPO. How we select the size of the...
So again, the whole thing is because your spigot has to be anchored somewhere. So first of all, once you try and localize the whole leak, what we do is either using a balloon, we inflate the balloon and see how much the balloon can be inflated up, and that is usually the diameter of the balloon is possibly the proximal end of your blocker. Or sometimes you open your forceps and see how much the forceps is being opened up to, and that can be...
Come out with NMAS because they are completely stuck with this one. the bucket handle work very well. Otherwise, it's very difficult
Yes.
to hold them and then get it out, because they are, and slightly sometimes we are pushing it with the sizes, because when we have limited size, they slightly pushed inside. So that's why the bucket handle, it worked very well.
No, absolutely. The whole thing is that we also tend to place this bucket handle, as you rightly put it, because it just helps, facilitates an easy removal for the blockers.
Yeah. Even with their button big also, because they have very small the head for that hold to the legs.
The things that people have used and pulmonologists, especially intervention pulmonologists, we like we said yesterday, we tend to beg, borrow, steal. We want to do. We've never had the opportunity to have everything with us, so we tend to use a lot of stuff with the other specialties, use and see how it works. And sealants is a topic in persistent air leak, which is consistent with that. So basically, we have borrowed and sort of copied from what the gastroenterologist does, what the intervention radiologist does, what the surgeons have been doing, and we've used a lot of these modalities that have been available to them. And so if you look at it, so just reiterating the facts, so what you have here is what you have here is the leak, and once you're done with sort of localizing the leak.
Thank you, Arjun, for the excellent talk.
With these agents, is it only cyanoacrylate, or have you ever tried another agent? I actually tried to go to the surgical OT to use this Tisine, but the challenge was to find a long
catheter. Yes. So again, that one thing with hydrogel also, you need to find a catheter which will take both the nozzles at the same time, and you are able to use it. So those are the challenges if you use something beyond the cyanoacrylate glue. Our experience per se has been limited. It's very limited per se, and on top of that, it is only limited to cyanoacrylate gel.
Dr. Arjun, how do you measure the size of the leak?
See, a lot of these leaks are actually post-surgical. So sometimes, the surgeon is able to tell them as to what is the size of the leak, or they have looked at the radar. It's not clearly mentioned. They've just
Surgical. So you see the stuff, and then you can measure the size of the fistula. It's visible, I think. That is what. The other thing was that I'm very much interested in the Chinese paper where they've injected 30 ml, 50 ml, you said.
30 ml, 20 to 30 ml.
So what were the complications reported?
So they said that both the Watanabe and this one had about 11 or 12% initial hemoptysis that happened. Other than that, they have not reported any increase in infections per se.
But if you're injecting that's
it's quite quite intuitive that way. But they have not really reported any increased risk of infection.
I invite Dr. Jayachandra, Dr. Ritesh Agarwal, and Dr. Pattabhiraman to chair this session. Over to the chairperson.
Good morning. First presentation, we have persistent air leak or mechanical ventilation and the role of ECMO for its management, and this will be delivered by Dr. Rohan.
Good morning, everyone. Thank you to Dr. Mehta and Apollo Hospitals, Bangalore, for this opportunity. We'll be discussing.
Is now open for questions or comments. Yeah, Ravi.
Papers done, we ourselves had one which Hari had spearheaded, 9% leaks and so on and so forth. ECMO also came in COVID, the centers with 15-20 machines right now. Transplant also came in COVID. So one of the questions is, PAL in COVID, for example, and hopefully such diseases don't come, was taken up for transplant early. How would you look at it in light of whatever you've gone through?
So what I've seen with patients having very severe COVID as well, those who are on 100% FiO2s and were tided over the crisis, we've seen remarkable recovery in the lung. Now patients coming back with normal oxygenation, significant reversal of fibrosis. So I think consideration of a transplant early, probably if they were stable enough or could buy time on ECMO, we would have seen significant amount of recovery.
The second thing is, would you say there's a shift of mindset towards using technology like ECMO, if everything falls into place, to make your endobronchial strategy slash surgery more effective, because they operate on ECMO also?
Yeah, it is absolutely seen more and more use of ECMO in current practice. We've also had patients in COVID being on ECMO and done well.
Okay. When should the mechanical ventilation you give up and say, I can't do anything, this is not going to get better at all? Or should we get into all this, refer it to a center who's handling all this?
Yeah, absolutely.
The old time thought was just give up. They leak away, you try out ventilative strategies and they die.
No, now with the advent of ECMO, advent of these endobronchial strategies, obviously if you have the expertise, you deal with it yourself.
For most of the patients in best of settings, it does not happen. So, short of it, any specific ventilatory strategy would you recommend to assess, because there's always a discussion which ventilator mode you put them on, what do you do? So anything you want to do.
You have an ECMO in your unit, isn't it? Don't lie.
ECMO volumes by reducing that, right? You may be trying to reduce the leak, but on the other hand, how much of permissive hypercapnia can you tolerate? If you increase the tidal volume in these patients, then you may have a chance of increasing the leak. That's what we see. So where is this sort of balance which we achieve? And this is the old debate of permissive hypercapnia and how much can be accepted, because they keep on leaking, the tidal volume keeps on leaking.
So the concept of permissive hypercapnia, you would want to have a pH which is acceptable, at the same time you do not like...
One patient we go to pH as low as 7.1 also. Okay. But if the patient is elderly, has myocardial ischemia and so on, there you don't exceed, there you don't go below 7.3. There the risk is there. So that is one. We always try to use a blood patch, autologous blood patch fluorosis. That is the only thing which we can do at our center. We don't have a
chemical fluorosis affect you as a surgeon when you go in and do your job?
Yes, it will. So the one of which I mentioned also, one of the things which increases the
visible areas of leak, which you think are not important for you to do anything, or because you follow it up with a mechanical fluorosis, you're not bothered about those small leaks elsewhere.
Excellent question as usual, Dharmesh. So when
so thank you so much. The true global nature of the surgeon. So
this is not right.
According to this thing, because there is a size criteria which is mentioned for intervening surgical. You can do away only with fluoridesis in that, because there is a gray zone in that area.
So did you get the question, sir? So the question was, if there is a pneumothorax and there is a bleb which is more, or a bulla which is more than 2 centimeters, less than 2 centimeters, would you, and it is not leaking, would you still do a blebectomy or a bullectomy, or would you just do a fluorosis and come out?
So I go to the slide, and when there is pneumothorax, because of whatever cause, whether it is primary or secondary, as I said, the first is conservative management for a few days to see if the lung expands and the air leak stops. Then you convert an emergency situation into an elective situation. But following the indications, once we are in and we see a bleb, and let me tell you, most of the blebs that we have seen in the last 15-20 years have actually been less than 2 centimeters in size. And once you see a bleb, and it's not one, in fact only about 20% of the patients have one bleb, most of the patients have many blebs. So apical segment of the apex of the upper lobe and the apex of the lower lobe. And third in order of incidence is the bottom of the lower lobe along the diaphragmatic surface, the margin of it, where
Ravi has taken that and then kind of dissected it, put all the appropriate things, and then we had a lovely session, and the summing up was also very good. So if you have any questions or clarifications, you can address it now.
Lung expansion, or can you do it even with a slightly collapsed lung?
You could do it even in a collapsed lung. So it would work if it plugs, it can plug it, and then the lung can expand later, and then the same thing will work as a fluorosis also. We do not know whether it works as a patch or as a fluorosis. So it can plug, and so it's not necessary, it's not mandatory that the lung there has to be in a position as in other fluorisis. So that's no problem. We can go ahead and start.
Sorry?
Spontaneously take infection. And second question is regarding the sizes of Fogarty balloons for blocking the right main stem.
Okay. Okay. So can this be done in a spontaneous breathing? Yes, you could do with this.
Infected lung and an infected pleural space. We just go conservative or any intervention is necessary there. And if in such a case there is an we have got the case lead and there is already an MDR organism. So what do we do?
Ravi?
Managed to look at when you conveniently change the topic and put some beautiful prose to take it to his. What do you do? Because that's the story we face. There's a drain in there, there's been 2-3 weeks, it's infected and there's a leak over there. So that's a nightmare. So that is the category where whatever one can propose at this point on a practical adage, you have two different issues. One is infection and one is leak. And both are creating a problem. Now the issue is that if you can go in, you go in, because at that point you clear the infection, that means surgical by and large, and that gives them a chance to fix the leak with some patches or whatever. Again, hoping this is an alveolar pleural fistula, not a bronchopleural fistula. But if they can't go in, then it's a nightmare. What we have done at that point is either do prolonged antibiotics, do chest tube drainage which is going on, or do a medical thoracoscopy. Go in minimally, clear the loculations, get the patient fit to have a procedure, because spiking 1 or 2 degrees, you're not going to be able to do any surgery on them. And in that medical thoracoscopy, we often can see where the leak is. So if we can localize the area of the leak, then we go and block it from the other side. Can I advocate this as being a standard strategy? No. But the whole situation is out of the box. So unfortunately, infection and leak go hand in hand. Both take equal importance. You have to deal with the infection to take up any procedure, otherwise it's conservative all the way. So often it's treat the infection fast, do a procedure to clear the loculi, do whatever, and then address the leak. Often if they're okay, we'll take it up at the same shot. So if they're going through the medical thoracoscopy, okay, very quickly we'll take them up for a blocker or whatever sealant, whatever you need. But most challenging. And the idea of today's entire discussion is, please intervene before they go. And that is where patience is I really feel Australia and UK infections versus us. So, US also, and I may be biased there, but it's a personal opinion. We get infected very fast over here. So you have to have it to go in and fix whatever you want to before the infection comes. A long answer, but yeah.
Okay. I had an excellent series of talks, I would say, from everybody. Even yesterday, extensive coverage of foreign bodies, and today on PAL. I think we have got more coming in the workshops right now. I think now we break.
No, we actually have our cases now. It's in the studio. So, yeah. So thank you everybody for the next session. We invite our next chairpersons, Dr. Karan Madan, Dr. Rajni Bhatt, and Dr. Pawan Biraris. And you guys can take over for the 4 speakers who are there. We have approximately 40 minutes, and one leftover case from yesterday was there, Dr. Kaumudi, foreign body. So we will take that followed by that.
What happens is when you say that a patient has had a bronchoscopy done elsewhere, is whether you have access to only images or if someone has sent you an actual video. Sometimes, Dr. Mehta spoke about networking and referral. If one place doesn't have all the tools available, if you take a really good video and then send it forward to the next person, that's useful to them. But without at least a video, I would not just trust some images and a report. I would really want to have a look myself.
And just add one thing, that you'll have a look, see whether it is retrievable or not. Suppose the distal parenchyma is completely destroyed, like partial bronchiectasis is still acceptable for bronchoscopy management. But if you do not have a ventilating parenchyma, it's completely destroyed. Even if you remove the foreign body, the patient will still have symptoms. That time, a surgical management, first surgical management can be considered in those cases. However, yes, bronchoscopy becomes mandatory to have a look first, and whether you see whether you'll be able to successfully remove it or not.
Moving on, so the patient and family have opted for a bronchoscopy and removal. So this is the bronchoscopic approach. If we can, we are able to see that middle lobe it is showing a pinhole stenosis with only a small opening to work with. So at this point also there was this debate whether going for a surgical removal versus And we want to visualize the foreign body also. So controlled balloon dilatation has been done. We were able to dilate the middle lobe opening and wanted to visualize whether the foreign body is really there or not. So this is the video which is showing a controlled balloon dilatation of the right middle lobe bronchus. So after this, we were with a thin bronchoscope, we were able to visualize the foreign body which was impacted there over last 5 years, around 4 to 5 years. So then initially, considering the nature, thinking it to be an organic foreign body, attempted cryoprop, but it started fragmenting. So we had to remove it with the help of serotip basket and forceps. The piecemeals were removed with the help of forceps, and the foreign body in toto was removed with the help of serotip basket. This was the foreign body which was removed. Obviously it was fragmented. Yes. So video please. So this is the bronchoscopy, post foreign body removal, one surveillance bronchoscopy done later, just to ensure that there is nothing which is being remaining inside. And serial CTs also has been done just to see the progress of the bronchiectasis. There is some amount of stenosis still persists in the right middle lobe, which already was there. But patient, so the main point after bronchoscopy is he had over 4 to 5 years recurrent exacerbations, frequent hospital admissions for these infections and all. Post bronchoscopy, post foreign body removal, after treating with proper antibiotics, he is asymptomatic for the last 1 year, even though some amount of middle lobe stenosis is there, asymptomatic for the last 1 year with no infective exacerbations. So the learning point what we removed was arachinet. So it has mechanical and chemical properties which make it a complicated foreign body. Usually it can fragment, which makes the retrieval difficult. Another point with arachinet is it releases some of the agents like aripodin, papaverine and all, which enhances the granulation tissue formation through IL-4 TNF alpha pathway. It also contains large amount of copper, which is fibrogenic. So to retrieve such a foreign body, we need a plethora of interventional pulmonology tools in our bronchoscopy suite. We should be well equipped before attempting a foreign body removal. And patient with chronic respiratory symptoms, they should definitely be evaluated for a foreign body also. Thank you.
Is coming up. Are there any questions from the audience about this, the foreign body case?
And a distal foreign body, you've removed it, and what you make out, there is still a bit of malacia, and there's a raw granulation or a raw surface. So, what should be the approach of a follow-up bronchoscopy or a follow-up dilatation or any role of, these are questions which come in real life, whether you follow up that with a short course of, steroid or antibiotics. What's your take on this?
Do I have Dr. Kamadhi's permission to answer this? Okay. So it's been to put Arvind's a tent which has formed on it, and you don't know how to get there. So it takes a lot to realize that to get there you have to actually cause more harm. You have to go, get some pathway or a channel, which is what we did. After that, God bless, the foreign body came out, which is another challenge by itself. Then this third point 3 is the sequelae, which we know are going to happen, which is a small area, it's been there for a long time. The gentleman is mentally been told his lung is going to go. So you go ahead and do acutely whatever you have to do, it's inflamed, you keep it open. And then comes the inevitable scar, which you cannot predict. So the first bronchoscopy we do is based on stent analogy. The earliest stent stenosis happens at 3 weeks or so. So usually 3 to 4 weeks we'll call them. Do we prefer bronch or CT? Excellent question. Bronch is dynamic, CT is static. So we'll do a bronchoscopy usually. Also from the idea that if it's narrowing, we'll intervene at the same time. So it's convenient, all this counseling is done. If that is okay, then the next one cycles to 2 months and so on. No right answer current, and the panel, you guys can give your feedbacks. In our minds, for 6 months, if you're okay, you're going to stay okay. also documented by a parenchyma evaluation with a CT scan, because you may be great in your endobronchial evaluation, but if there is repeated infection and bronchiectasis happening, you have to open. Lastly, this patient is from Pawanland, Mumbai. So if whatever we intervene, we have to follow up or hand over to him. So that sort of thing was another problem. So when we realized that some stenosis is acceptable,
like utilizing what you have for
yellow 3, green 4, orange 5 and purple 6. That will be your starting station. We will have 25 minutes.
If I can have your attention. So, because we are dealing with some live animal models, so please make sure you're wearing gowns. Most of you are already doing that. So far, there will be 25 to 30 minutes per station. You will get enough time for hands-on. After the workshop is done also, there will be some free time if you want to put hands onto something that you will get. So station 1 over here is tools and techniques for management of persistent air leak. So people with red color codes, red patches, they will start with station 1. Station 2 is glue application for bronchopleural fistula management. That's on a live animal model. So blue color codes will start with station 2 and then move to 3, 4, 5, 6. Yellow will be with station 3. They'll start. Then green will start on station 4, which is management tools for management of foreign body. Orange is station 5, they will start from there, and purple will start with station 6. So 6 will move to 1, 1 will move to 2 and so on and so forth. Okay. After the I think 2 members help each other. See, I cut it further. I'm going to make a very small one. Take over suture material from here. This what the suture material what we are using for to make spigot is Mersil 0 reverse cut. So take the artery, hold it at the tip.
Once we place everywhere, we slowly start using one by one supplements.
Once you've reached out, you want your person assisting you to actually give you the catheter out. Alright. Hit and then come out. Yeah. Yeah, first air to sort of clear out the channel, then glue. So you will have a little bit of air, so that only if you have air, the entire channel sort of clears out. Otherwise, everything gets stuck. So you can see that injecting glue, this is saline. Then again air. Take the entire thing out. You're going to make sure that so you're going to wipe it with acetone, cut out the tip, and again wipe it once more with acetone. Okay, take the whole thing. Okay, so this is how you're going to do. The most important thing is go see, make sure that the tip is out. Initially, you will flush it with saline to make sure that the channel is clear, and then
what we have is the various intercostal drains and stuff. The pigtail catheters, so you have this regular ICD out here, you have the various pigtail catheters out there, and there are other types also which are there. Now, majorly what they can be connected to are your interfaces. Now, this is quite common with the Romo seal bag. There is an underwater seal bag also, which we were just talking about inside. Now, there are other devices also. Now, the major thing with these is you cannot quantify what is your leak, if at all there is. You cannot really quantify. You can just see qualitatively, okay, the bubbling may be appear more one day, the bubbling may appear less the other day. So what we have is certain devices which can actually use to quantify all these leaks. Now, one of the major devices that we have started using the last 2-3 years is the Synapy drain. Now, this is basically, again, this goes and gets connected to your whatever chest tube is there. This is the valve.
This will allow you to hold it a little bit like this. There is patience there, right? So it will completely, you can vary. There are ratcheted ones which allow you to hold and then you can wiggle and move it around. Or there is like which allows you to grasp and then so you learn to just, feel free to play around with these. The idea is to see how these instruments work on the station by handling the instrument and seeing what happens with this. And what do you want to do to be able to do a very slow control? You are working along with this. This is always going to be about perfect coordination. Whoever is assisting please feel free to handle all of the instruments.
This dip into the water, it takes ice crystal, right? So if you have vegetable foil material, it has some moisture in that, and if you cook that and then you freeze it, you catches the irritation. Slowly you can yank it. Multiple usages. So the difference is if you are doing a biopsy, you can always use a smaller probe. It's 1.1, 1.7. We have 1.1, 1.7, 1.4. So therapeutic work, you can use a bigger probe. You can have a more freezing effect and you can catch it. For the biopsy, you can use a smaller probe. The recent study says the smaller probes are as good as the bigger probes. Lesser amount of tissue which we capture is good. So the therapeutic work can always carry a bigger probe for this one. Biopsy can use a smaller probe. But in case for those things, small probe. Yeah, that's a good question. So basically, you should try to avoid touching the mucosa when you try to freeze. If you yank it out with the frozen mucosa along with it, it's going to cause bleeding. Okay? Try to make sure the foreign body is quite
The videos also very good. Yes, sir.
forceps है forceps दे दीजिए सर राइट चालू कर इसको ऑन किया वेंटिलेशन Open. Sure. So where is the spigot? उसके साथ ये लगा हुआ है. No. So you don't have to make this string to it, okay? ठीक है. Anyways. So animal में बहुत secretions आ जाते हैं. So here going into the. So let's come to the correct. The bronchoscopy is in place. Suction मिलेगा तो अच्छा रहेगा.
Sir, suction है क्या sir?
Perfect. We will not follow the right and left. We are on the left side actually. That's the problem with the tip. That's the one that's very good.
That's the right one?
Yeah, that's the right. Right, we are here at the basis. Okay.
Only we will put on upper one.
Let's see what's the
that will have to discuss. Lot of times because it's not an absolute contraindication. Unless and until the patient is planned for transplant immediately, then you would.
Somebody doesn't get your hands on this thing because once the session is over, you have enough time to come back again.
Come on. That is where the cost of the catheter is. So you cannot be using something which is very expensive. You cannot be using something which is very cheap. If you take a TPN which is indigenous to Canada, it will not be more than 100 to 200. So that you can afford to. No, see, we usually have access only to sign generally other things, cost wise also, because it's easily available. So we have used only
Basically, the only difference is that we come in two syringes, but it comes in contact. Yeah, so there is a particular syringe that comes. So when you flush there's a bunch of ingredient from.
I'm taking. So you cannot have. You try the other one. This is these kinds. This is not one. Where is it?
Sir, it's also will not fit, sir. Not good enough.
Last 5 minutes.
You don't have foreign body clothes, you have only bags.
Okay, use the same thing that I not right.
We are not.
Okay, take it. You don't have much time.
So you see that
Boys versus girls will have orient yourself where exactly the position for this is the right side. And in business segments, there is a leak. In this segment, there is a leak localized. So we'll go with the forceps now. And so take the forceps, please. Close the forceps. You know how to close the forceps. Close it. Let's go to the working channel of the therapy. Choose a therapeutic bronchoscope and let's secure the airway with the endotracheal tube or rigid bronchoscope. Rigid bronchoscope is preferred because you can isolate which segment you would like to treatment. Yeah, it can be done with as well, even LMS, but depends on the severity of the patient. Okay, so now we are going to catch hold of this pivot. Open it. Let's hold it here. Close. Hold it tightly. You're okay? Holding it. You're not going to release it. Open it one more time. Okay, catch it. Okay. So we will go with this now into the desired segment. Let me just push it ahead so that our vision, if you get it more closer, you'll not be able to see what is happening. Back to the cranium. In big bronchos, you will have many divisions, so it's very difficult to differentiate right and left. But you can go into the basal segment here. You may have to maneuver to guide it to the basal segment. It's very interesting visit.
And then then Sina becomes an anti-oxidant.
Regarding the sizing of the devices, so that you can keep everything with you.
So now what we do initially we used to size it with the theory with the help of, say, as I was telling you, can inflate the balloon or with the forceps open as I showed on the video also. But then it's always better.
And one more thing. One time is enough.
And you get it out nice and whole. If it is like what you saw in that case.
Madam, as sir told, 50% is tablet is is it not completely act of cost?
We can't be sure of it, sir. I wouldn't want to leave
And one more thing.
We know we damage the
I have an old bronchoscope. One of the main
So the idea is always a combination of any.
Okay, sir. Smile, smile. Say one, say ye. Thumb in.
Thank you guys. Back to the pigs and goats.
Action band.
Style